Ladies and gentlemen, you are very brave people. I'm very happy. I realized that we were very ambitious with this program, but you're still smiling at me, which is good. And loss to follow-up is very low. I can tell you this is very low. I'm very happy. So now we have the last topic of the day before we start the GCP course, and this is about how to interpret clinical trial data. And I would like to take you through some trials that are not that recent anymore, but they're very good examples what we should look for when we interpret clinical trials. So let's start with this. So these are the main questions when you check out a trial or a publication. You always have to ask these three questions. Why was it done? Who was studied? And how was it done? These are the three very simple questions. So I picked the IMPROVE IT trial. That's not very recent. It's from 2014, but it's a very good example to my eyes. So why? What were the goals of the trial? And you have to keep this in mind when you interpret the trial findings. So what was it? So the research, the trial was an ACS trial testing lipid-lowering therapy. So the first research question was, does lowering LDL cholesterol with a non-statin agent, ezetimibe, okay, you don't hear me too well, I guess, does lipid lowering with a non-statin agent, ezetimibe, reduce cardiac events? And before that, it was not proven. You're all aware that ezetimibe is around for a very long time, but there was no good evidence that it's actually doing not just lowering LDL cholesterol, but also reducing events. So this was research question number one. Does it lower events? Research question number two is the LDL hypothesis. Is even lower even better? So if we go lower than the targets that we had, does that translate into less events? So these are the main questions of the trial. Okay, so who was studied? Patients with acute coronary syndrome, LDL cholesterol between 50 and 125, so rather low. There were some exclusion criteria. So very simple, typical cohort. How was it done? So we had 18,000 ACS patients who had standard therapy, and those people were randomized to receive either simvastatin 40 milligrams or simvastatin 40 milligrams plus ezetimibe. So this was the comparator. Okay, so we had 40 milligrams of this versus 40 plus ezetimibe. And then the patients were followed, and this was a classic trial which was event-driven. So this was not limited by time or patient number. This was event-driven. And as you are aware, the trial was supposed to run for 3 years, and it took 7 years to have all the events. So it took very long. Okay, so when you will look at trial results, check out the baseline results. So typical cohort, like 60, the age was 65, and again, women were underrepresented, a third diabetics, so that was very clear. And look at this. This was the LDL cholesterol at study entry 95, which was rather low at this time. So 95 LDL cholesterol to start with. Okay, so surrogate lipid lowering. So look at this. So this was what was achieved in the two different groups. So both groups went down with their LDL cholesterol. And in the end, we were comparing approximately 70 with approximately 53 milligrams per deciliter LDL cholesterol. So a mean difference of approximately 17 milligrams per deciliter. You have to keep that in mind. Okay, so this was what was achieved. So this is the primary endpoint in the intention to treat analysis. You see these Kaplan-Meier curves separating at some stage continuously, and after 7 years of treatment, there was a relative risk reduction of 6% in a combined endpoint of cardiovascular death, MI, unstable angina, coronary revascularization, and stroke, so quite a broad endpoint. We had 6% relative risk reduction, number needed to treat of 50, so you treat 50 patients over 7 years to save one event. This is the result of the trial. So now the question for you is, what does this mean? What is the interpretation of this trial? And when you have this question, you have to keep in mind the research questions of the trial. So number one, can we lower event rates with a non-statin agent ezetimibe? Question number two, is even lower even better? So we are comparing a target LDL of 70 with a target LDL of approximately 53 in this trial. So what is the answer to these questions? The answer is yes. So number one, we can lower events with a non-statin agent that was on top of statin treatment. And number two, even lower is even better. I have to say that a relative risk reduction of 6% is not much, but if you look at the research question, absolutely fulfilled. So we have answers to these questions, so the trial met its objective, for me, very clearly. Of course, beyond that, you have to ask the clinical question, what does that mean for our patient? Do we really want, the 6% risk reduction? What does it mean? Just to put this into context, you've seen this before. When you look at the achieved LDL cholesterol reduction and you compare the endpoint reduction, this trial is completely on the regression line that we know from other statin trials, for example. So lowering LDL cholesterol, the amount of lowering translates absolutely perfectly into the lowering of the event rate. So it is what we could expect. We couldn't expect more. Still is the question, when do you use this drug? This is a clinical question, but from a trial perspective and interpretation, I think it's quite clear the trial met its objectives. Okay, so the next thing is about endpoints, primary, secondary endpoints. So you see the primary endpoint was this combination here, statistically significant, and now there's a variety of secondary endpoints. I don't want to go into details. So my question for you, when you check out the secondary endpoints, are the secondary endpoints valid? Can we take the information and say, okay, so these endpoints are also reduced? What is the answer to this? The answer is yes. You have to check the primary endpoint. If the primary endpoint was statistically significant different, so the primary endpoint met its objective, then you can go for the secondary, not the other way around. And sometimes we do have this. The primary endpoint was not different, and then people say, oh, well, but in the secondary endpoint, we saw this and this. That's not okay. Okay, if your primary endpoint is significantly different, then the secondary endpoints are valid. Okay, now the levels of endpoints. The hardest endpoint is always all-cause mortality. Very difficult to achieve. You need many, many patients to see this. You have to wait for a very long time, or you need very sick patients. And that's the reason why, for example, heart failure trials still use this, because you have sick patients and people die, so you can count this. In many other trials, it's not possible to see differences. So we have all-cause mortality. Then we have cause-specific mortality. For example, fatal myocardial infarction, fatal stroke, something like this. Then we have the non-fatal clinical events, still relevant, non-fatal MI, hospitalization. Hospitalization is always important for cost as well, so that's important. And then we have surrogates, LDL cholesterol. Okay, and we know many trials where LDL cholesterol was lowered very nicely, but it did not translate into endpoint reduction. For example, nicotinic acid, for example, fibrates only to some extent. So it is important to prove that we don't only influence surrogates, but also endpoints, and this is why we need these trials. Okay, so when you look at these endpoints, in this trial you can see all-cause death, no different, cardiovascular death, not different. There was a reduction in myocardial infarctions and ischemic strokes, so in non-fatal, I think, clinically relevant events. Okay, now subgroup analysis, that's always very important. If we have, let's say, a positive trial, we want to find out who benefits more or who is in danger. So when you look at this, the rule of the 4 Ps, very simple. Subgroup analysis, they need to be pre-specified. They need to be adequately powered, so you can have you can draw conclusions. They need to be plausible. It has to make sense what you're looking for, and they need to be practically relevant. You can check anything in subgroup analysis. You can do, 100 different subgroups. Does it make sense? No. So the rule of the 4 Ps is important. Now I show you some subgroups of the IMPROVE trial again. So sex difference, it is relevant, it is plausible. Age, diabetic status, prior lipid-lowering therapy, baseline LDL cholesterol. So all of these make sense. Now when you look at this, what do you need to interpret the relevance of a subgroup difference? You have to check for this little thing down here, the P for interaction. Okay, and you can see here there's a star showing that this subgroup analysis, there's a significant interaction. It is not in the others. So you might think the point estimate here is on the other side, so there might be a difference, but there's no significant P for interaction, which means there is no difference, which means you can apply the findings of the overall study population to the subgroup. A difference is here, and this is diabetes. Here we do have a significant interaction. So when you look at subgroups, don't only go for the point estimate, check out the level of interaction, the p-level of interaction. So, and now what was done was a subgroup analysis in the diabetic and versus non-diabetic cohort, and you see the Kaplan-Meier curves here. So you see that in the diabetic cohort there was a more pronounced relative risk reduction. You see that diabetics have a higher risk, we know this, and you see the risk reduction, the relative risk reduction is greater in the diabetic cohort, but you see no difference in the non-diabetics. So this is very important for interpretation. So again, my question, what does it mean? Does that mean that we should only treat diabetics with this drug? Can we take this from the data that I've showed you? The answer is no, you cannot. You have one finding, you have an overall study cohort. This is what the trial was made for. We do see a pronounced effect in diabetics, but this is hypothesis generating. So if you really want to find out if this population benefits more, you should go for another trial and just check out diabetics and treat them in a randomized fashion. This will not happen with ezetimibe, but this is what we can take from this. Okay? Any question? Yes?
So you said that you can actually interpret or get some results from the subgroup analysis because it was not randomized for that purpose.
Right.
So what's the purpose of showing subgroup analysis if it shows you something which is not correct?
Well, it's not about correctness or not. It shows you a tendency, and it may show you some special groups that benefit more or that are more in danger. But from a statistical point of view, you have to test this separately in another trial, in an interventional trial. But of course, it shows you potential subgroups that benefit more or that are more in danger. So it is important information.
Are there statistical methods to overcome this barrier? Because some of the trials show their subgroup analysis in big events and they try to hypothesize and affect the treatment with that. So,
well, if you follow the 4P rule and you have a very big cohort, saying like a large study population, you have more safety. Yeah, sorry?
There is also another point. If you perform the block randomization, actually...
Wait a second, Gianluigi, could you use a microphone for your answer? There's one here because... It should be working.
So if you perform a randomization for according blocks, as Alexander explained, actually the randomization takes also account of, for example, let's say they did a block randomization taking account of diabetes. If they had done this, you would have also the same number of patients and patients matched according diabetes. So it means like at the same time you can also test the hypothesis in patients with and without diabetes, but this is not the case.
Could you pair the patients in order to get some more valid or rigorous?
If it was pre-specified when they planned the trial, yes, because with block randomization you can do this, but this was not the case.
Weren't diabetic patients at pre-specified subgroups?
Yeah, but it's difficult. It's different to have a pre-specified subgroup analysis and to have a block randomization.
So isn't it logical if you pre-specify a subgroup to do a block randomization according to the subgroup?
I agree with you, but it's impossible to have a block randomization according 10 variables. You should enroll, I don't know, 1,000 and 1,000 and 1,000 patients because, yeah.
Let's say if you have the assumption in a trial like this that you especially want to know about diabetics, you could incorporate this and say if you have a different sample size maybe and you do block randomization to have a good allocation. But of course, sometimes you don't know this, right? So you go for the trial and then you look for important subgroups, say, oh, there is a difference, which you could not anticipate that much, for example, okay? So then you wouldn't go, of course, at the beginning and have block randomization like this.
But for example, if you think about a study about anticoagulants, let's say something like that, and you are exploring a population like heart failure patients and not patients with atrial fibrillation and without atrial fibrillation, you may think that maybe it makes sense to have block randomization according to atrial fibrillation because it could make the difference. You agree?
But I have to say, I mean, this is also theoretical stuff. But let's say if you have a big subgroup, a very important subgroup, and you have a very, very significant signal, this may still lead to considerations, for example, and to give a warning for treatment or something like this. So it does make a difference. It is important. It's just that you just have to know that the trial was obviously designed in this way to have a full cohort that includes diabetics and not diabetics in particular, you know?
My question, do we have time?
We never have time, but it's important to discuss because...
Very important question because a lot of trials, a lot of sub-analyses that are presented, and we want to know which one you can trust. What
Right.
to look for.
Okay,
Right.
Yes, that was my question, because we try the sub-analysis to identify populations that are at an especially high risk. So what we say, like, for example, in this trial, that diabetic patients are at a higher risk. But we can't say on the other side that non-diabetic patients are at a lower risk.
Right.
If I
Right.
understand correctly
Yes.
what you're
Yes.
saying.
Yes.
So
You identify a group that is at higher risk and that may benefit more from lipid lowering.
and then the opposite group is not at a lower risk, or
You can't, well, they are lower risk. I mean, you can tell from the event rates that they are lower risk, but you cannot draw the conclusion that you should not use the drug in this population and that it has no benefits there. That's the point I'm making.
Sven,
Yeah.
there is also another point. Very often, here the randomization scheme doesn't work because patients were not randomized according to diabetes and not diabetes. So these are unadjusted analysis because the randomization for this kind of analysis doesn't really work. And another point is usually subgroup analyses are not adjusted for multiplicity. It means that there is high risk of having false positive. So maybe some p-values could be significant, but they are not really significant because there is high risk of false positive. So they are just hypothesis generating. Then you need to test the hypothesis.
Before we go on, think about, we have this tomorrow in the workshops, and you can ask this guy. No, Alexander, the other guy. It's the other guy. You can ask all your questions again or in more detail tomorrow, okay? But that's why I'm showing this. I think it's very important when we try to interpret trials, or let's say when companies come and show you something, say, hey, look at this, you have to be aware of what you're looking at. Okay, I will switch to a different topic now, which is anticoagulation. So I'm using the ROCKET-AF trial that tested whether rivaroxaban is non-inferior to warfarin in patients with atrial fibrillation at increased risk. So this trial compared rivaroxaban with warfarin in patients with atrial fibrillation, 14,000 patients. The statistical methods were clearly shown. So here you see the testing and the confidence intervals here for testing of superiority, non-inferiority, and inferiority. So very clearly stated what is, for example, non-inferiority and what is non-inferiority. And so you can see here that's the primary efficacy endpoint, stroke and non-stroke embolism, systemic embolism. And they said, okay, non-inferiority means on treatment population, protocol compliant on treatment, and superiority was tested first in the on-treatment cohort and then in the intention to treat cohort, which is different from other trials, and that's why I'm showing it. So this is the result. As you were aware, there was a lower rate of events of stroke and non-systemic and systemic embolism in the rivaroxaban group. Clearly, non-inferiority was met. So, and then they went on for superiority testing. And now you have this. If you look in the on-treatment cohort, there's significance for superiority. And if you look in the intention to treat cohort, there is not significant for superiority. So you can imagine the difference of interpretation from a statistical and trial perspective and a company perspective. So now my question for you is, what is the right way? Should we use intention to treat, or should we use on-treatment analysis for superiority? And in this case, it makes a big difference. In other trials, it was not like this, but in this trial, it makes a big difference if you have just non-inferiority or if you have superiority. So I think it's clear the gold standard is the testing in the intention to treat analysis if we talk about superiority. And here's just one example what could make a difference. In the intention to treat analysis, you're looking the full study period, and if you just look at this, on treatment, no event, and just after stopping the treatment, one event occurred. So this would be included in the intention to treat analysis, but not in the on-treatment analysis. This is, by the way, exactly what happened in the ROCKET trial. When patients were switched back to warfarin, there were more events. But anyway, this is just showing that when you go for the full study period, which is done in the intention to treat, you see or you collect more events. And there's more safety of the analysis, if you may. So the standard is, if you look for non-inferiority, you go for on-treatment analysis. If you check for superiority, it's the intention to treat analysis. And safety is clearly always the on-treatment analysis. So this is the gold standard. Any objections? No. Very good. Objections from our statistician over there, who's, of course, an MD and not a statistics person. Okay, very good. Any questions to this? We may also discuss this tomorrow because, again, tomorrow there's a lot about non-inferiority, sample size, why is this done, why superiority, using what. Okay? The main rule is always statistical assumptions are always looking for the worst scenario. You always assume the worst, and this is why it is chosen.
Then I have one question.
Maybe.
If you're saying that we're always looking for the worst case scenario, why is safety only measured on treatment? If we stopped following up and a person experienced some sort of an event after.
Yeah. Well, there's always.
The drug still be in effect?
Well, it could. There's always a kind of delay after that. So on treatment in this case always means you stop treatment and then you have that's predefined, some time after that, so and so many days, weeks, whatever, to account for that. But obviously you want on treatment because you do not want to dilute your effects when the patient is not on drug. But there's always a time period pre-specified that is also covered for exactly that purpose. Okay, so my last example that I would like to use is something completely different. It's not pharmacotherapy. Now this is about device therapy. And I picked one example, which is a PFO occluder, so a device that is used to occlude a hole. For those of you who are not familiar with that, we talk about patients who suffered a stroke that could not be explained. We called this cryptogenic stroke in the past. Now it's called embolic stroke of unknown source, ESC. So in this population, other sources of stroke, for example, carotid disease, for example, atrial fibrillation, were ruled out. And then in some patients, we find a persistent foramen ovale, which means you have a hole in the septum and the atrial septum, and we know that clots can pass from the right side to the left side. So interventional cardiologists like myself jump on that. We say, hey, that's easy. We can occlude that. That's very simple. It's more simple than heart surgery. You just go in with a little thing and you occlude it, and that's it. So of course, this needed to be tested, and neurologists are always more cautious than interventional cardiologists. So the RESPECT trial did exactly that. So those were patients with a cryptogenic stroke with an evidence of persistent foramen ovale, and they were randomized to receive either an occluder system called the MPLETS occluder, the PFO occluder, or medical therapy. The trial was quite big, I have to say, for a device trial of this kind, 980 patients, randomization 1-to-1. So approximately 500 got the device and the other half got medical treatment. So when you look at, this is just to introduce you into the topic. So when we look for procedural safety, there were no clots on the device, no embolization. Atrial fibrillation was identical between the groups. That's important because when you put in an occluder into the septum, you may cause atrial fibrillation. So this was not the case. TAA was the same thing. Bleeding was the same thing. There was one difference, more vascular complications because you have a vascular access to the femoral vein. Obviously, if you poke into a vein, you can produce bleeding, which you cannot do if you do medical treatment. So that was the only difference. So that's for safety. Now for the success, you can look at different definitions. So when you check this, the success rate, there are technical terms which you really have to check. Technical success means you bring in the device, it's where you want to have it. Procedural success was defined that there was no problem, for example, within a certain time period after the occlusion, and then effective closure was tested 1.5 years later, where they did a bubble test to see if still bubbles pass through this hole or not. So different definitions. What you can take from these numbers, all of them are about 90%, so it's a very effective method. So, as in pharmacotherapy trials, there was an intention to treat analysis, gold standard. You always do intention to treat. So in the intention to treat analysis, you see this result. You do see a completely different Kaplan-Meier analysis. So with lower event rates in the device group, this is event-free probability. So this means less events in the device groups, but not in the medical group. But when you look at the p-value 0.08, statistically not significant, okay? You do see a big difference here. So look at the numbers. The numbers of events were very low, and that's the problem with this kind of disease. It's a rare event. So we have patients who had an embolic stroke, and we want to prevent the next. And it's a rare thing to happen again. So that's why it's difficult to see differences. And here we have 9 versus 16 events. And there's no one story that I have to tell you. So you see quite a difference here. 50% relative risk reduction, but not statistically significant. So the interpretation of this is very simple. This procedure is not effective, okay? It's not statistically significant. So there's a very sad story. Although this is a very rare event, people were waiting for their procedure to take place, and in this waiting time, they were randomized to get the occluder. So they're included in the intention to treat analysis, right? They were randomized, so they're in the analysis. And in the waiting time, 3 patients suffered a stroke, a recurrent stroke, before having the device put in, okay? Which means they're counted as events in the intention to treat analysis of the device arm without having a device. Okay, so that's the assumption. So now when you look as the as-treated cohort, which means the device was put in and is basically in the patients, you see this, 70% risk reduction, significant p-value, everybody's happy, you know, a little lower event rate, still low numbers of events, but this is statistically significant, but it's on treatment. Okay, then they did something, they called this the totality of evidence. When you look at this is the intention to treat. Is this evidence as treated? Is this? Check out the different years of follow-up, 5 years. Obviously, if you wait longer, you have more events. But the interpretation of this trial was very simple. It's not significant. It doesn't do anything. Now we know there's an even longer-term analysis, which was just published in the New England Journal, that the device does protect from stroke. Okay, now it's clear even from this trial. So I have 2 questions for you to raise. And the first thing is the following. So there were many meta-analyses, different systems. So just check out this. There were 2 device forms. One is the Amplatz device, which looks like this. And one was the so-called Stark-Close device, which looks like this. When you check out these things, they look completely different. And in terms of interventional cardiology, they were handled completely different. So now you see this. When you look at the Amplatz device, there is a significant benefit. The Starflex device, there was no significant benefit. And now there's something which you have to check. That's the heterogeneity that you do in meta-analysis. The heterogeneity said there's no statistically significant heterogeneity. So my question is always, how can that be? Look at these things. They look completely different. They're handled completely different. How can there not be a different heterogeneity? So why is this? No. Good guess, but it's not the case. It's very simple. This is testing a principle. It's testing the strategy of occlusion with a device versus medical therapy. And that's why there's no heterogeneity, although the device is different. But that's the explanation why there's no different heterogeneity. It's hard to, I think, grasp, but this is actually the explanation for this. Now, when you look at this analysis, this is intention to treat. Again, the point estimate is on the right side, but it's not statistically significant. When you look in the as-treated analysis, there's statistically significant benefit in terms of PFO occlusion. So you can imagine my question now. Should we really go for intention to treat, or should we check as-treated cohorts in device therapy, or should we do something that I might call modified intention to treat? So modified intention to treat is a principle where you randomize a patient to a group, so he's in the intention to treat analysis. He's not in the as-treated analysis because in this case has not received a device. But modified intention to treat means in pharmacotherapy, the patient receives at least one pill of his study medication. Then he's included in modified intention to treat, which means nothing has happened in the waiting time in between. So this could mean for devices, maybe we should do modified intention to treat, which means the patient is actually on the table. We try to put in a device, and then he's counted in regardless of whether he gets the device or not, because safety is included then. Obviously, if you do a device treatment, there may be a problem. Patients may suffer a stroke, a bleeding, whatever, which is important for the interpretation of a strategy. So a modified intention to treat would account for that. So you try to put this thing in, but it maybe doesn't work, but at least it's still counted. So this is more a statement. I think this should be the way to go, but it's not like this at the moment. But you should think about this, okay? And now I have my last slides, which are not about trial interpretation. If you have, by the way, do you have questions? You had a question, I think. No?
I'm stopping myself.
Why? We're here for discussion.
I agree with you. There's no logic why you use intention to treat with the medical device if the patient didn't receive it at all.
Yeah.
Well, it's the nature of testing principle, which says intention to treat is the gold standard from a statistical point of view. This is the best way to go. I personally have the same problems with you. It doesn't make sense, right? So that's why I think it should be in a different way.
What is the gold standard in pharmacotherapy? Is it intention to treat, or should a patient receive at least one tablet of the drug or one dose?
Well, it is still intention to treat, but some trials have used the modified intention to treat principle.
Some oral anticoagulant trials, I think
Right.
they engage.
Yeah, the endoxaban trial.
But the point is there are several definitions for modifying intention to treat analysis. So at the moment it's not really clear if it's...
The patient was on the way to the doctor's office to receive the drug and got hit by a bus. Is he included in the intention to treat analysis?
Yes.
Is that an adverse outcome?
Well, it is definitely a very bad outcome for the patient, that's for sure. But in the intention to treat, he would be counted.
He was randomized and he went to receive the...
Exactly, and he died.
But
But there's at least adjudication. This would account for total mortality, not for cardiovascular, for example. There's one... Yes, sure. Do you want to use the microphone for that? If you like, there's one on your table. In this case, if you have a comment, I think it's good to use the microphone. You can just go out.
Yes, one of the things that I've learned in epidemiology is that you should always put the randomization procedure as proximal as you can to the intervention. So if you would randomize the patient on the cath lab just before entering the cath lab, that shouldn't be much difference between intention to treat and modified intention to treat. But if you wait a month,
I agree.
there can be a significant difference. So you can look at this when you design the trial.
Yeah, you are completely right. It's completely right. And in stent trials, especially in ACS trials, for example, that's obviously the case. Then you have a problems with ethics sometimes, because you have a very short period of time. Patients can't really think about anything. They're lying there with chest pain. I don't know if anybody has done STEMI trials. It's really, really bad. When you have a patient lying there and said, please sign here, sir. We give you this new drug, and said, yeah, just go ahead. Ethically difficult. We need these trials for sure, but it's difficult. Yeah, but this was very, very... It's a very rare event, and that happened in this trial was really not expected. But I think it's a very good example. Okay? Good. So I want to come to my conclusion, and I leave you with 4 slides. I would like to say goodbye to you with this. I can't be here tomorrow. You have great other people here tomorrow. So this is just about body weight and the upcoming holidays. So we all are aware that increased body weight, obesity is on the rise, and people die not only from, but the majority dies from cardiovascular disease. So obesity is not a good thing. So if you think you can change your body weight by skipping breakfast, okay, I have to tell you that's not a good idea. This great paper checked out morning eating habits, skipping breakfast, having low energy breakfast or high energy breakfast, which is more than 20% of the daily energy. So when you look at this, if you skip your breakfast, you have actually a higher chance of getting obese, having metabolic syndrome, or having atherosclerosis. And just look at this. This was CT scans done, right? So you see, for example, subclinical, non-coronary, coronary patients, people skipping breakfast have more atherosclerosis. So think about that. You shouldn't skip your breakfast, okay? So if you belong to the yo-yo type of guy who, brings on body weight and then go down, up, down, this is not a good thing. The New England Journal tells us the higher the body weight fluctuation, the higher your cardiovascular risk. So be aware of this. And now this brings me to my last slide. So the upcoming holidays are dangerous because you can see this is the weight change during the holidays. And just look at this. This is Christmas in Germany and the United States. So check this out. So there's a high rate of body weight changes, okay? So that's dangerous. So think of it in terms of cardiovascular prevention. Think of what you do. Or if you want to put it in the words of the authors of this great paper, the less one gains, the less one has to worry about trying to lose it. So with this, I would like to say goodbye to you. And we have something else for you today, so you're not done for the day. Debbie Rolfe, who's in the back, can't wait to start with you. We're a little bit behind time, Debbie. But we're done with the sessions for today. So what we will do now is Debbie's GCP course. Of course, you must have a coffee break now. Maybe we can shorten this coffee break if you like. And then you come back and Debbie will do the GCP course. Tomorrow it will be less intense than today, I can promise that. It's only half a day. You have workshops, you can listen, you have nice people to chat with. So tomorrow will be compensating for today. So with this, I would like to thank you. And thanks for staying. We have 0 loss to follow-up, which is absolutely amazing. So thank you very much.